for Shield Healthcare. Welcome to the webinar titled Wet to Dry Dressing, the Good, the Bad, the Options. Participants will be in a listen-only mode. If you have a question, please type it on the chat box to your right. Participants are also eligible for 1 CEU credit, and we'll tell you how to get those CEUs credit after the webinar. At this time, I'd like to introduce our speaker for today, Dr. Don Wollheim. He's board certified general surgeon by the American Board of Surgery with over 25 years of general surgical experience. Dr. Wollheim has extensive expertise in wound care, medical legal consulting, general and vascular surgery, and advanced science education. At this time, I'd like to pass the presentation over to Dr. Don. Dr. Don.
Hey, Eric, thank you so much. And I do want to thank Shield Healthcare. I am Dr. Don Wollheim. Most people know me by my alias, Dr. Don. I'm one of the instructors for Wound Care Education Institute. And I want to say that I'm honored that WCEI has asked for me to be the presenter of this program, Wet to Dry Dressings, the Good, the Bad, but most importantly, your options. If you're not familiar with WCEI, it's an institute that was founded around 2002 by the two nurses that you see there. They are the co-owners, and they have been so active with WCEI all these years. In fact, when I think about WCEI, and I've been an instructor for them almost 10 years, I think of these two owners. The person on your left is Donna Sardina. The person on your right is Nancy Morgan. And I will tell you that they've bent over backwards to help this webinar be successful. They helped this webinar to make me look good. If you don't know what WCEI is, it's an organization that teaches healthcare providers, healthcare clinicians in regards to wound care. They have 3 main courses: the WCC, or the Wound Care Certifying Course, the DWC, the Diabetic Wound Certification Course, and the OMS, the Ostomy Management Specialist Course. Combined with the National Alliance of Wound Care and Ostomy, the attendee who participates in the course, if they meet all the criteria, they can sit for certification. Irrespectively, it'd be the WCC, the DWC, and the OMS. As of August 2016, they reached a landmark. Over 20,000 healthcare providers have the WCC certification. But in spite of their success, their overall goal has remained the same: to improve the management of wounds for patients across the United States. So let's get into this webinar. When you select a dressing, it's a complex problem. We need to understand what's going on. We need to be sophisticated about it. We need to be as evidence-based as possible. Regardless of where you practice, whether you're in an urban area, rural area, or exceedingly remote, you will be held to national and international standards of wound care. The overall goal should be, we want to heal the wound as quickly and as painlessly as possible. The longer that wound bed is exposed to environmental contaminants, the greater the chance that there could be an underlying soft tissue infection. And as long as we have that possible soft tissue infection, there's a greater chance that the underlying bone may become infected with osteomyelitis. So what we need to do is we want to heal the wound as quickly and painlessly as possible. We may need to control or eliminate causative factors. We need to provide the support for our patients, because in reality is all we can do is set up the scenario so they can heal their own wounds. To do this, we need to maintain normal physiological local wound environment as best we can. Now, when we think about a dressing, we need to think about, are we going to use this dressing as a primary or as a secondary dressing? A primary dressing is what touches the wound first. If it's like an antibiotic powder, it'll be the powder. If it's like an antibiotic ointment, it'd be the ointment, or enzymatic ointment, it'd be the ointment. If it may be something like a hydrocolloid, whatever touches the wound the first is a primary dressing. Every dressing beyond the primary dressing is a secondary dressing. But to use the dressing appropriately, we need to know its overall indications as well as its contraindications for the dressing. For example, this wound that you see in the photograph here, if it had a lot of drainage from it, exudate from it, if you put a transparent dressing on top of it, a transparent dressing or a film has no absorptive capabilities. It'll just build up underneath it. What we want to do is set the stage for moist wound healing principles. This was established around 1962 when the United Kingdom surgeon, Dr. George Winter, did a fairly sophisticated but simple experiment. He created partial thickness wounds on the back of pigs. Half of them he covered with transparent film to represent the stratum corneum, the outside layer that was incised as he cut the wounds. The other half he left open to environment. And what his goal was to find out which wounds would heal the faster. And as it turned out, it was the wound that had a moist environment that would heal the fastest, which means at that point in time, 1962 is when moist wound healing principles evolved. Some of what we look at when we pick a dressing is, are we going to need to control the exudate? That's the drainage. How about the bioburden? Bioburden refers to the antimicrobial load within the wound bed. Is pain an issue? Is bleeding an issue? Do we have multiple issues that we need to address with our dressings that we select? If we select a dressing and we use it in a contraindicated manner, then we're not doing our patients a favor. One thing to keep in mind is this. The more frequently we change a dressing, every time we take that dressing off, it's going to take about 4 hours for the wound to warm up to the point where we had before we took the dressing off. So for example, if we have a dressing that we change TID 3 times a day, in that 24-hour period of time, 3 times 4 or 12 hours, that wound is going to be colder or cooler without the dressing than with the dressing on, versus a dressing that we take off once a day. Only 4 out of 24 hours is that wound bed cooler. This cooling of the wound bed has a negative effect on wound healing, because by the thermal regulation principles, we're going to get vasoconstriction. The capillaries at the level of the wound are going to get smaller, so we're going to have less blood flow to the wound bed, less cells of repair going to the wound bed, less oxygen and nutrients going to the wound bed. And a cooler wound bed is going to slow down the wound healing. As we'll learn in a little bit, we'll have an increased chance of infection. The temperature is a result of the dressing selected. In the upper photograph, that's a gauze dressing. The gauze dressing is the coolest dressing that we can apply to the wound bed. The lower photograph is that of a foam dressing. That's the warmest dressing. There'll be less overall vasoconstriction with a foam dressing than with a gauze dressing. This thermal difference is related to the dressing that we select and also related to the frequency of the dressing change. We have to take in consideration what the manufacturers say, because they're the ones who have done the research. They're the ones who got FDA approved. So for example, let's say we want to use a contact cast on a patient who has a diabetic foot ulcer, and we want to use a foam covering up the diabetic neuropathic ulcer. If the total contact cast is a 7-day, but the foam that we selected is only good for 3 to 5 days, there's not going to be any inherent properties that's going to be on the foam because it's in a 7-day cast. So that being said, we're going to have to change the cast more frequently at day 5 or day 3. These TCCs tend to be like around $150 per dressing. So all this we need to take in consideration, the indications and the contraindications. And we're going to go back to what the manufacturer says, because they're the ones who've done the research. And from their research is how they got FDA approved. It may sound intuitively that a gauze dressing that uses saline and tape is least expensive. But that's only looking at the unit price of the dressings. There's more that goes into the expense in the unit price. For example, labor at changing a dressing or the ancillary things that we need, such as gloves and waste disposals. You can imagine if you're changing a dressing 3 times a day versus a dressing that you're only changing once a day, that the dressing from a labor cost and a cost from the ancillary supplies for the 3 times a day dressing is going to possibly be 3 times more expensive than the once a day dressing, regardless of the unit cost of the dressing. Now, if we're using a dressing that may be cheaper per unit cost, but does not heal up the wound as quickly, then what can happen is that we're going to be taking care of the wound for a longer period of time with the least expensive dressing than if we used a more expensive unit cost dressing. Bottom line is this, that the more expensive dressing that requires less frequent dressing changes may result in shorter healing times, and overall, when we take into consideration not only the unit cost, but the labor involved, the ancillary supplies, and the duration of care, this more expensive dressing may actually be the much cheaper, less expensive form of therapy. So this program is about wet to dry dressings. I want to talk about the good aspects of it, but I also want to talk where evidence has brought us to our point in 2016. Wet to dry dressings is considered a non-selective mechanical debridement. Debridement is actually a technique of eliminating non-viable tissue from the wound bed. If we go through the 4 phases of full thickness wound healing, the first phase of full thickness wound healing is what's known as the hemostatic phase. That's where the bleeding stops, and that's where our platelets will secrete growth factors to continue the wound healing process. The next phase is the inflammatory phase. At this point in the inflammatory phase is where the wound bed is cleaned up. We can think of it as using the phagocytes, such as the neutrophils, and eventually the macrophages. They perform what's known as phagocytosis. They will surround, they will ingest, and will digest foreign antigens because they have proteolytic enzymes in their cell body. Once the wound bed is cleaned up, we then go into the proliferative phase. At this point in time, the fibroblasts play a role in producing collagen. The collagen is going to be our scar tissue to fill up the wound bed. A collagen is a protein molecule. Actually, it's 3 protein molecules wrapped around itself in a triple helix. And so now the wound bed is going to heal up, fill up with the scar tissue, the collagen. But in order to do that, we have to get blood flow there. And so there's going to be what's known as angiogenesis. If you take the word apart, angio refers to blood vessels, genesis refers to the creation of. And so within our scar tissue, within our wound bed, within our collagen, we're going to get new capillary loops coming on in. So we're going to fill up the wound bed with granulation tissue that is rich blood supply. Then there's going to be a contraction of the wound bed. And then finally, we're going to resurface the wound with new epithelial beds or new epithelial cells. Once the wound has resurfaced, we're going into our next and final phase of full thickness wound healing that can last up to a couple of years. And this is a maturation phase. During this phase, the collagen fibers realign, increase the overall strength, and those capillaries that fill into the wound bed are now going to regress because it isn't needed. That's why our wounds look very red initially, but as the capillaries go away with time, the color of the wound bed actually, or the wound itself, lightens up. So debridement, whatever technique, including wet to dry dressings, is only intended for the inflammatory phase of full thickness wound healing. This is where we want to clean up the wound bed of the non-viable tissue. We have 2 main categories of debridement. Selective debridement, where the technique only will eliminate the non-viable tissue, versus non-selective debridement is in the process of getting rid of the non-viable tissue. Unfortunately, you need to sacrifice some viable tissue. Now, with selective debridement, there's 3 techniques that we'll talk about. Non-selective debridement, there are 2. And one of the techniques is mechanical debridement. With mechanical debridement is where the wet to dry dressings play a role. The technique is basically there's going to be an application of sterile saline or water moistened woven gauze. Bring it out, lay it into the wound bed. We're going to let it dry out over a period of time. And then approximately 4 to 6 hours later, we're going to pull the gauze out, as you can see in the photograph. We're going to pull the gauze out dry. We're not going to re-moisten it. We're going to pull it out, and out will come the non-viable tissue. But unfortunately, some viable tissue also comes out with the wet to dry dressing technique. What I describe, however, is not standardized. Some practitioners re-moisten the gauze before removal. Technically, this is not wet to dry dressing. This is a moist to moist dressing. Some clinicians utilize solvents other than normal saline. For example, some clinicians may use betadine or even dilute betadine. Some clinicians may use Dakin solution, and its antimicrobial in Dakin solution is hypochloric acid. The frequency of change is variable too. When I trained in general surgery in the 1970s and practiced beginning in the 1980s, we were changing every 12 hours just to make sure that we got all the non-viable tissue coming on out with our dressings. Unfortunately, this process led to viable tissue coming out. Indications for wet to dry dressings, if you're going to use it, is only intended in the inflammatory phase of full thickness wound healing. The idea is to get this non-viable tissue out, like you can see in the photograph here. This is what we want to get out. This is non-viable tissue. The technique of wet to dry dressing is considered mechanical debridement, and it is one of the non-selective forms of debridement. As I mentioned before, the downside to wet to dry dressing changes and being non-selective is in the process of getting rid of this non-viable tissue that you can see in the photograph, unfortunately, you're going to sacrifice some good tissue. And this good tissue may give problems to the patient. Wet to dry dressing, indicated as a mechanical debridement, absolutely is contraindicated to be applied in the photograph that you can see on the top of your screen. This is a wound with granulation tissue that is in the proliferative phase of wound healing. We do not want to use any form of debridement, be it mechanical or the other 4 techniques utilized in the proliferative phase of wound healing, as seen in the 2 photographs. Now, is this really a problem? I mean, why do we need a webinar in regards to wet to dry dressings? I mean, is it an issue? And the answer is yes. There was a retrograde study running between 2002 and 2004, which was a chart review examining the frequency of ordered wound dressings on top of the wound bed. Over this 2-year period of time, there was 202 patients that charts were reviewed. Of these 202 patients, the wet to dry dressing was ordered 42% of the time. There was no other form of therapy that was ordered more frequently than wet to dry dressing. As you can see, there was no other form of therapy that was ordered even greater than 10% of the time. First runner-up was the enzymatic debrider, which is about 7.5% of the time. As it turned out, which doesn't personally just surprise me being a surgeon, is most of the wounds that were treated with the wet to dry dressings were surgical wounds. This is how we were trained. This is how I trained in the 70s. This is probably how everybody who taught me prior to the 70s was trained and how everybody after my training taught other residents. 70% of the time, the most wounds that were open wounds were ordered by the surgeons, 73% of the time. Most of these were surgical wounds. What is disconcerting to me is the last bullet on the slide. Upon assessment of the use of the mechanical debridement, wet to dry dressing mechanical debridement, the assessment indicated that it was not clinically indicated in approximately 80% of the time when it was ordered. This should be worrisome to all of us. What are the overall disadvantages of the wet to dry dressing? Well, we know it's not selective, and in the process, it's going to remove some viable tissue. For example, in the upper photograph. What does this equate to the patient? Well, one thing it equates to the patient is that it can be uncomfortable. It can hurt. It can lead to bleeding. The other thing is studies have shown that bacteria are able to penetrate 64 layers of gauze from the surface down to the wound bed. Now, in your lower photograph, I don't know if that's 64 layers, but that's a lot of gauze to try to hold in place. So if you're in the OR and let's say you finished your work, you have the incision closed, and you put gauze down. You're not going to put 64 layers down, that'd be one of the best. And let's say you ask for tape from the circulating nurse, and she hands you tape that may have been in her coat pocket or in a drawer. That's not sterile. So if you put that on gauze, less than 64 layers thick, you don't have a sterile dressing. At best, you have a clean dressing, which may not be one of the goals that you want to have with your patient leaving the operating room. As we can see in this photograph, gauze dressing, be it woven, those big open mesh, or the non-woven, that padded gauze, whether you cut it or not, we can see in this photograph that lint is being left behind, that residues of the dressing is being left behind. And if it gets underneath the wound bed as it reepithelializes over, down the road, we can get a granuloma. It may get infected, very similar to what any surgeon has experienced with suture abscesses. We get this constant draining from the incision, and this will occur until we get the non-absorbable tissue out from underneath the depths of the wound. Gauze is our coolest dressing. That means that we're going to have the most vasoconstriction. Those capillaries are going to be very narrow, which in turn means there's going to be less blood flow going to our wound bed. And with this less blood flow, there may be less oxygen. So the tissue itself may become hypoxic. We need oxygen for all of our cells to survive, because oxygen is what ends up producing the energy unit of a cell, and the energy unit is ATP. If a cell is well oxygenated, it will have enough ATP, such as 36 molecules of ATP per molecule of glucose that is being broken down. What happens if we're in a hypoxic environment? We're not getting enough oxygen there. Well, now what we're having is we cannot produce as much ATP per molecule of glucose. And instead of 36 molecules, we're only producing 2 molecules. Our cells of repair in the inflammatory phase, our neutrophils, and our macrophages, which are phagocytes, are working in overtime mode to get rid of this non-viable tissue, the foreign antigen. They're going to need all the energy that they can get. And if they're only getting 2 molecules of ATP per molecule of glucose versus 36 when we're in an oxygen setting, they're going to be less efficient. You know what may happen is that the bacteria may win, and there may be an increased problem with infection. Also, it's a physical property of the hemoglobin molecule, that when it's in a cool environment, that it's going to hold on to the 4 molecules of oxygen that it has per molecule of hemoglobin and not release it to the tissue. Once again, this disadvantage of vasoconstriction in a cooler environment overall will impede the wound healing and actually can increase the susceptibility for infection. Let's take it to the next phase of full thickness wound healing. Now we're going to require our fibroblasts to lay down collagen. If they're not running on all cylinders and they're not getting enough ATP to function normally, that wound healing not only may be affected by infection, but it overall may be slowed down. That can be the ill effects of just talking about the temperature change with a cooler dressing such as a gauze dressing. If you look at the lower caricature, what can happen when you remove the wet to dry dressing, just like this little guy with his slingshot, as you remove the dressing, what comes off is bacteria. And it can stay in the wound, it can get on the patient. You know what? It could actually get on the clothes of the examining clinician. And there was a period of time in both the United Kingdom, and I actually saw one article in Surgical News in the US literature, where there was consideration about possibly clinicians not wearing neckties when they're making rounds, because this could be a vector of transmission of bacteria from one patient to the next, to the next, to the next. One of my students actually told me the past week that one of the hospitals she works out of, they've actually outlawed the wearing of neckties in making rounds. So we can get this disbursement of bacteria with taking off the wet to dry dressing. The disadvantages of wet to dry dressing, first of all, we have to understand what its indication would be. If it's it would only be indicated for the inflammatory phase of wound healing. The photograph that you see is not the inflammatory phase. We see viable tissue there. If we put a debrider agent on top of viable tissue, over granulation tissue, over epithelialization cells, this is absolutely inappropriate. This would be utilizing it in the proliferative phase of wound healing. So with the deposition of the collagen can adhere to our gauze. As we take that off, the collagen that we need to be our scar tissue can come off with the gauze. It can cause bleeding. It can affect the angiogenesis that we need. And if we have new layers of epithelial cells, those too can come off. So any utilization of debridement in the proliferative phase is contraindicated. Bottom line is, we will eventually slow down the wound healing process and overall increase the risk of the soft tissue infection. And the longer the chance we have a soft tissue infection that may take weeks or a month or two to eliminate, we may get underlying bone infected with osteomyelitis. Healing of osteomyelitis can take months, if not at all. There's this perception, and the perception is this: it's a misperception. Gauze is cheap, saling's cheap, tape is cheap. That being the case, that the wet to dry dressings is the most economical form of wound care. Actually, as I pointed out in one of the earlier slides, because we may have to change it more frequently, and we're going to require more dressing changes and more material and longer periods of time to heal up that wound, this inexpensive wet to dry dressing just made up of gauze, saline, and tape may in the long run may be more expensive to wound healing. Because we're going to have moisture added to the wound, as we can see in the lower photograph, you can see the maceration, that ring of white tissue surrounding the wound bed. That can occur with wet to dry dressings. Okay. Is this from Dr. Don or Dr. Don Waldheim only? Is this from Wound Care Education Institute only? Actually, the utilization of wet to dry dressings is considered substandard wound care by various regulatory entities. And I want to point out the second line there to the right. It is considered substandard care by CMS. We got to take into consideration what Medicare and Medicaid thinks, and we would support exactly what they're saying. It is substandard wound care. But why do people still utilize, still order wet to dry dressings? And it's the most frequently ordered, even though they may understand that there are complications with it, that they understand that it is not endorsed by various regulatory agencies, including Medicare. Well, probably a big factor is the clinician's training and their experience. I was trained doing wet to dry dressings. It served a very useful purpose. We did not have many options then. I felt comfortable doing it. May feel comfortable continuing using this in the inflammatory phase of full thickness wound healing when we need a mechanical debridement. It may be used because gauze and tape is cheap. Yes, unit value, but overall cost may be more expensive. Maybe the clinician is scratching their head and they don't really understand all the negative aspects of wet to dry dressing, or they may be unfamiliar with the advanced wound care dressings. So if we're saying that we should stop the wet to dry dressings, we need to give you some options. Is there enough evidence to exclude wet to dry mechanical debridement techniques for the 21st century? The evidence supports yes. It's an absolute contraindication to utilize it in the proliferative phase of wound healing. It's a relative, if not an absolute contraindication, to use it as a mechanical debrider because we have better techniques. We should consider this an all or nothing proposition. I will not badmouth wet to dry dressing technique. People have had their wounds aided by wet to dry dressing technique. But I think what we know at this point in time, we should discard it. It is sort of like the analogy of open versus laparoscopic gallbladder removal. I trained in the 70s. The only option we had then was the open cholecystectomy, where we made those big scars, big incisions. And that carried well into the 80s and probably the early 90s. It wasn't until the end of the 80s, starting the early 90s, that it became evident that U.S. surgeons learned how to do the laparoscopic minimally invasive cholecystectomy. Where now, if somebody was going to routinely do a gallbladder operation, they would start out with the lap chole, not with the open cholecystectomy. The open cholecystectomy for years, decades, served a useful purpose. It helped a lot of patients. It probably saved a lot of lives. But nowadays, it should be not considered the standard of care initially, but the laparoscopic chole should. I can see the analogy is it served a great purpose before, but now evidence supports a different technique. It does no good for me to tell you we need to discard something without telling you what are our options. So let's talk about the 5 techniques of debridement. 3 are selective, where only we remove the non-viable tissue. 2 are non-selective. In the process, we're going to remove viable tissue in the process of removing the non-viable tissue. So what are the initial selective debridements? Again, we're only going to remove the viable tissue. The slowest form of debridement, as you can see, is autolytic debridement. This is where the body's own enzymes will dissolve the necrotic tissue. All we have to do is follow the principles of George Winters and maintain a moist wound environment. If the wound bed is dry, the only category that we're going to add is the hydrogels. That's the only category that adds moisture. If it's wet, then initially we may try out something like a gauze or a hydrocolloid. A foam or a hydrocolloid. If that doesn't work, then something like an alginate that can absorb more. If that doesn't work, something like a hydrofiber. Aquasol is one of the trade names. Autolytic debridement is the slowest form of debridement. That being stated, It is not recommended for infected wounds by itself. The next form of selected debridement is enzymatic debridement. This is where we apply an enzyme, collagenase, to the wound bed. This will be selective. It's going to cut, it's going to divide the collagen molecules that are holding the non-viable tissue to the wound bed. As it cuts it, now with the next cleaning, this non-viable tissue will leave. For enzymatic debridement to be effective, it needs to be applied once a day. No more frequently, no less frequently. The last form of selected debridement is biological debridement. This is where we place live maggots in the wound bed. Some people say there's a yuck factor to it. I suppose there is. What biological debridement will do will promote the growth of fibroblasts, which will now stimulate the next phase of full-thickness wound healing, which is a proliferative phase of wound healing. We're only going to leave the maggots down for 1 to 3 days. At that point in time, their tummies are full, they're going to sprout their wings, and they want to fly away. In general, multiple applications are required. So the 3 types of selected debridements that we just went over, where only the non-viable tissue is removed, is autolytic, enzymatic, and biological. We have 2 techniques of non-selected debridement. And remember that with non-selected debridement, not only does a non-viable tissue get removed, but also some viable tissue is sacrificed. Mechanical debridement is one of the 2 main categories. This is where wet to dry dressing falls under. The definition of mechanical debridement is external forces that is great enough to separate or break the adhesive forces to the necrotic tissue. If we look at whirlpool that we can see in the lower photograph, or irrigation that we can see in upper photograph, these are collectively known as hydrotherapy. They're going to have a certain force. It's going to be measured in PSI, pounds per square inch. If we irrigate a wound bed, I should say if we clean a wound bed with a pulse of 1 to 3 PSI, all we're doing is clean the wound bed. That's like flushing it with a syringe without an angiocatheter on it. Well, ideally what we want to use is the force being 4 to 15 PSI. And that's what we're going to look at for our hydrotherapy irrigation. Anything greater than 15 PSI, those surface bacteria that we could usually get off, not only with irrigation but cleaning, can be driven into the depths of the wound. Towards the end of the 1970s, water pick came out, and a lot of surgical departments, where I trained also, purchased a lot of water picks, not to clean the teeth and the gums of their patients, but to use as an irrigant for the wounds. The problem is that the pressure with a water pick is going to be around 80 PSI. So the surface bacteria that we easily could have gotten rid of with cleansing the wound, with irrigating the wound, is now driven into the depths of the wound. And this may be problematic. And finally, the last type of debridement, which is non-selected, is sharp debridement. This requires a sterile technique, sterile prep, sterile drape, sterile instruments, and a sterile dressing at least for 24, preferably 48 hours after the procedure. If it's done at bedside or in the clinic, this is known as sharp conservative. It's done in the operating room. This is sharp surgical. To me, it is the procedure of choice if we believe that there's an underlying question of infection. But I'll tell you, I've reviewed charts where patients have shown up to these clinics, and the surgeon documents or the wound clinician documents that the wound bed had 100% granulation tissue, and they cut into it to see if it bled. No, that's in the proliferative phase. All forms of debridement, including sharp debridement, should only be for the inflammatory phase. So the 2 types of non-selected debridement, mechanical, which is where wet to dry dressing falls under, and sharp debridement. So we've had 5 different techniques. What about dressing options? We got to give you something. We just can't take away an important tool from you without giving you something. Let's talk about the various dressings that are available. Some of them may actually stimulate debridement in and of themselves. The only dressing that will add moisture to the wound is a hydrogel. It's 90% water in a gel base. It will soften the necrotic tissue and help maintain that moist environment that George Winters talked about. It comes in various formulas. If you look at the upper photographs, the upper right, that is your amorphous hydrogel. The center picture is a sheet, and the lower picture is the gauze that's impregnated with it. Some of the hydrogels will come with various antimicrobials, such as silver. Silvercept has silver in one of the trade names. Anicept, trade name, will have hypochloric acid. To me, it is absolutely the best dressing for various findings, various tissue that we have in the base of the wound. For example, in the upper photograph, the clinician is pulling up on the muscle belly, and that cord-like structure that we're seeing is a tendon. We can see the muscle. It should be used over fascia. Fascia is basically the protective covering that we can see over muscle. It also covers arteries or vessels and nerves that we can't see, or ligaments that attach bone to bone. Over granulation tissue, the natural environment of tissue is a moist environment. This is the only category that will do that. Transparent film. As we can see in the upper photograph, this is a dressing made of a polyurethane coat with an adhesive. This can protect the wound bed from such things as friction, but immediately on the wound bed, as we can see in the lower photograph, it's protected from bacterial invasion. Because it has no absorptive capabilities, any moisture under this transparent film will remain there, and this will actually give us a moist environment. We can visualize the wound bed. It will waterproof the underlying tissue. To me, if you're not going to put 64 layers of gauze in the operating room, put the number of layers that you want. Instead of using the non-sterile OR tape, use a transparent film on top of it. It is probably the dressing of choice when we're dealing with like the neonate, a kid 30 days of age or younger, where no tape should be applied to the skin. At that point in time, we're going to use a non-alcohol-based skin sealant, and on top of that, we're going to use a transparent dressing as tape. It is, however, one of the two groups that is contraindicated over an infected wound, transparent dressing. Contact layers. If you have not utilized contact layers in your practice, please reconsider, or at least consider this product. It has no absorptive capability, but what it does is very important to wound care clinicians. It's going to protect the wound bed from trauma, which includes the trauma of dressing changes. One of the ways that it does that is some of these contact layers can stay down for 5 to 7 days before you have to change it. A contact layer is always considered the primary dressing, what hits the wound bed the first. If you utilize the technique of negative pressure wound therapy, I would strongly encourage you to always have a contact layer as a primary dressing. This will protect the ingrowth of the granulation tissue going into the foam, as we can see in the lower photograph, or pieces of foam breaking off into the wound bed itself, becoming a foreign body, later on become a source for infection. Collagen dressings. Collagen dressings are really not intended for the inflammatory phase of wound healing. They're basically meant for the proliferative phase of wound healing. What they're going to do is they're going to help the appropriate deposition of collagen in the wound bed. It's going to facilitate the proliferative phase of wound healing. One of the theories behind the way the collagen dressing works is that we have slow deposition of collagen because at the wound bed we have proteolytic enzymes, basically what's known as matrix metalloproteinases, that is destroying the newly laid collagen. Now the MMPs not only can affect the wound bed, but if we put a collagen dressing on top of it, it will attack the dressing, which is great. There's going to be less slowing down the wound healing process. Hydrocolloid is a dressing that we may consider utilizing in a wound in the inflammatory phase. Its description is containing a gel formulated agent in an adhesive compound, laminated together with a flexible resistant outer layer. It will protect the wound, and it's the best protection of any wound from such things as incontinence or protect the intact skin because it is absolutely occlusive. Nothing from the outside can go in, but nothing from the inside can come out. One of the things is that when you take a hydrocolloid off the dressing, as you can see in the lower photograph, it's leaving a residue behind. This residue will clean up. There's an odor that can be left behind, but this odor is not a clinical odor because it clears up with cleaning the wound bed. Because of this property of being totally occlusive, it also is contraindicated in affected wounds such as a transparent film. We can place it under Uniboots, venous insufficiency wraps, under total contact cast. But if we're going to use any of these products, such as a TCC, for 7 days, we have to put a hydrocolloid down that has a 7-day wear time. If you're employing negative pressure wound therapy and you cannot get an airtight seal, one thing you can do is take a hydrocolloid, like you're seeing in the upper photograph, and outline the wound bed and just cut out that wound bed. And so now when you lay the hydrocolloid around the wound bed, it is sitting there in the peri-wound tissue. Or you can window paint it like in the lower photograph. The transparent film of the negative pressure wound therapy can now run the potential of getting a greater seal if you utilize a hydrocolloid in the peri-wound tissue than if you're having problems maintaining a seal. Foam dressings. Foam dressings are described as a polyurethane foam with a small open cells capable of holding fluids. It will provide insulation. Any fluid it holds will be moisture against the wound bed. Any dressing that does this will stimulate this moist wound healing process and autolytic debridement. It is the warmest dressing that we have, which means we're going to have less vasoconstriction, less ill effects of those capillaries vasoconstricting, getting narrow with a foam dressing than any other dressing that we have. If we have hypergranulation tissue, what's that? It's where you have granulation tissue that goes above the edge of the wound. If you put a foam dressing on with a little bit of compression, that can knock it down. That's minimally invasive. The other two options are use a chemical cauterant, such as silver nitrate, or sharp debridement. Foam dressing more than likely will take care of it. It too, like a hydrocolloid, can be used under an Uniboot, venous insufficiency wraps, or total contact cast. But we have to match the wear times. If any of those dressings we want to have a 7-day wear, our foam dressing has to have a 7-day wear. Some of them come with various antimicrobials in it, or surfactants. A surfactant is a molecule that actually has two properties, a hydrophilic water-loving versus a hydrophobic water-hating. If you look at the lower photograph, on the right, that is a foam without the surfactant in it. And what we're getting is that exudate is sitting there. Versus the left photograph where there is surfactant in there, the surfactant is starting to get rid of that exudate. If we cannot get the absorption that we need with a foam or a hydrocolloid, let's go up the absorption scale. We may go to an alginate. An alginate is a dressing made of calcium or sodium. It's wrapped in fibers from seaweed. It has better absorptive capabilities. We can use it to control moderate to heavy wound drainage. When the alginate is appropriate, when you take it off, the alginate will go from the fibers that you see in the upper photograph to one that looks like a moist gel. That's when you know that the alginate is appropriate. Alginates have hemostatic properties. And the way the hemostatic properties occur is that theoretically is that the calcium will leave the dressing and go into the wound bed, and calcium will have an effect on that coagulation cascade. But that taken in consideration, that may be one of the reasons why the calcium alginates are contraindicated in the pediatric population, because of the transmission of calcium to the wound bed. And we have to worry about our pediatric population of absorbing various types of products. It's not used for dry wounds or dry eschars. If you look at the upper photograph, here you have a ligament. It's dry. You put an alginate on top, it's going to dry it even more. If you put on tendons that are dry, it's going to dry them even more, and they're going to lose their strength. How can we tell that the alginate is inappropriate? Again, it looks like the fibers that you put it on. Days later, when you take it off, it looks just like you put it on. Some people actually will put on the wound bed and hydrogel and then put an alginate on it. It makes no sense. Because what's going to happen is the alginate isn't going to help the, the hydrogel is not going to help the wound bed to maintain its moisture. It's going to get absorbed into the alginate. And so we have less creativity, less capability of the alginate. Some come with various antimicrobials, such as silver. Some, as you can see in the lower right photograph, come with honeys. If the alginates do not absorb well, there may be other products, a composite dressing. Some of them absorb less than the alginates, some of them can absorb more. What a composite dressing is a dressing that has a combination of not only the dressing, but its adhesive. To me, it is the ideal sterile operative dressing because it's going to come out of a sterile container. You have the dressing, as you can see in the lower photograph, and will come with its adhesiveness with it. If you have a dressing that has difficulty staying on an area, maybe try a composite dressing. Wound fillers. Wound fillers are out there basically to fill wound cavities. They come in various availabilities: paste, granules, powder, beads, gels. We can see in the lower right photograph, you stack those up. Those wicks, stack them up until you get at a high enough level for absorption. Last category I'm going to talk about is specialty absorptives. This is a multiple layer dressing, highly absorptive fibers. One category we're going to talk about is the Hydrofibers. And the only trade name I'm going to talk about in this is Aquacel. Belongs to this group. Now, if we look at the specialty absorptives, the upper photographs, not being an Aquacel, we can see that this dressing with absorption can actually absorb a lot of exudate and become almost a pillow. The person holding in his hand is Aquacel, and it's only going to absorb right over the wound bed. That's known as vertical wicking. It's going to absorb what's coming up, but laterally it is going to remain dry. There may be antimicrobials in these specialty absorptives. For example, we have Aquacel and we have Aquacel AG. AG is basically the Latin symbol for silver. Aquacel AG, the way it works as an antimicrobial is not topically per se. The silver does not affect the bacteria in the wound bed itself. It has to be absorbed into the dressing, and now the silver of Aquacel AG will destroy the bacteria. So what is our past? What is our summary? Wet to dry dressings have been employed for generations of surgeons over many, many decades. At the time they worked. At the time, however, we did not have that many options. I remember in my training, they came up with one enzyme that now we don't use on open wounds. We really did not have the advanced wound dressings. It was in the past. It served a useful purpose. It has helped heal thousands, if not millions of patients. But time has come to let it go by the wayside. We need to follow moist wound healing principles. These have been established since 1962 by George Winters, that United Kingdom surgeon who he found out that with a moist environment, wounds can heal twice as quickly than in a dry environment. If you think about a wet to dry dressing, it goes from moist to dry. This is not following the principles that Dr. George Winters had proven back in 1962. It may be a brash, bold statement, maybe a brash statement, but a lot of regulatory people agree. Wet to dry dressings should be completely abandoned at this point in time. There's no question. It's hard to adopt new technology in any area of medicine. If you're of my vintage, you know what a paper chart was. Whether you wrote out your notes or you had your notes transcribed. That was simple. Now, you have to get in a different mindset. Those electronic medical records, that may be initially very difficult where you're thinking, what have I gotten myself into? It is hard, but the more you use it, the better it'll be for you. We know that change is extremely difficult. There's absolutely no doubt in our mind that change is extremely difficult. But just like the standard routine open cholecystectomy has given way to the laparoscopic cholecystectomy, we should give up the utilization of wet to dry dressings and instead use other techniques of debridement. I talked about autolytic, I talked about enzymatic, I talked about biological, I talked about other types of debridement such as mechanical and sharp debridement. We should use other techniques of debridement instead of wet to dry. We now can use our advanced dressings that we may not have known about before. The hydrogels, the transparent films. We had with it now the contact layers, the collagens, the foams, the hydrocolloid, the alginates, the wound fillers, the specially absorptives, the hydrofibers that fall into specially absorptives. We have a lot more tools in our toolbox in the 21st century than what I had in the 20th century upon my training and practice. I do want to thank you very much for participating in this continuous education webinar. And the webinar basically is wet to dry dressings, the good, the bad, and hopefully I've given you a lot of options instead of the wet to dry dressings. Thank you for attending. I'm going to turn this webinar over to Eric.
Great. Thank you, Dr. Don. That was a really, really excellent presentation, really informative. I appreciate that. We've got a bunch of questions here, and I apologize. We've got over 900 people on this webinar, so it's a standing room only event here. So, Dr. Don, you're basically like the Ricky Martin of wound care here. So I apologize, we're not going to be able to get to all the questions, but there are some really good questions I do want to address. Dr. Don, how do we get doctors to change this practice? What is the polite way to speak to their physician on adopting this therapy then?
That's a great question, Eric. And the way I would respond to it is, you need to understand, you have to walk in their shoes. They were trained with the wet to dry dressing. They, in their minds, have healed up thousands of wounds utilizing the wet to dry dressing technique. Change is difficult. The best way to convince somebody is this. One is try educating them. Maybe ask them to listen to this webinar at a later date. The other thing is, we're available for them. We're available for them. In the handouts, we have ways of finding WCEI. You have my own personal email address. We are there to help them. But we have to understand that change is difficult. Now, if you're a nurse and a wound care nurse, one of the things that you can do is, hey, doc, I attended this webinar. I have this knowledge. Can I try a different technique than wet to dry dressings? Will you allow me to do this for a period of time? But be realistic. If you're going to say, well, they ask you, well, how long do you want to do it? Don't say 1 to 2 to 3 days. There's not going to be any change. 2 to 3 weeks. And after a while, they'll get much more comfortable with it. And you'll rise in their level of knowledge. You'll be much more valuable to them. But, you know, more importantly, you're going to be much more valuable to your patients.
Great. Thank you, Dr. Don. There are a bunch of questions on how to get this slide, slides. So this webinar is being recorded and will be posted on the website that you see in front of you, www.shieldshealthcare.com/community. So if you missed any portion of this webinar, you can go to the recording and play it back. Unfortunately, we're not able to hand out the slides. They are proprietary to WCEI. But again, if you did miss any portion of this webinar, go back to the recording and it will be posted on that community page. We're at 9:50. we got time for one more question, and I apologize if you did type in a question. We will send it to WCEI to answer those questions. Dr. Don, can any petroleum-based products such as Neosporin have similar benefits to hydrogel?
It depends upon what you use it for. Now, when you're talking about something like an antibiotic, we got to be careful utilizing an antibiotic because even topically, we're worried about resistance. And so, for example, if we use something like Bactroban, just repetitively, we're worried about resistance to Bactroban, which can have a negative effect on our treatment and of our care with MRSA patients. But when you're talking about things such as a Vaseline-based gauze or an adaptic, some of that actually, those are called impregnated gauzes. Some people actually utilize them in a similar fashion as a contact layer.
Great, thank you, Dr. Don. I apologize, we're right at 10 o'clock, so we do have to end this webinar. Before we go, take a look at the site on the screen, www.shieldhealthcare.com/community. We have really great blogs, really great wound articles, and we will have the recording dry webinar posted on this page. If you do want a copy of the new Shield Healthcare Wound Management Guide, it looks something like this. It actually shows you how to identify different wounds and how to match the dressings to those wounds. And it was co-written by Shield and WCEI. So to request your copy, go onto our community site, shieldhealthcare.com/community. There is a landing page for you to enter your information, and we will send you a wound management guide. If you do want more than one, please talk to your local Shield Healthcare rep, and they can provide you with more. So next slide, please, Dr. Don. So to obtain your CE units, there's a handout download on the right-hand side of your screen. Click on that, those handouts for instructions to receive your CE units. If you are in a group setting, you can jot down the names of folks in your group and then submit it to WCEI. So check your spam folder. All the attendees will take that list and send you a link on how to receive your CE unit. So I'd like to thank Dr. Don for that really great presentation. I'd like to thank WCEI for all their hard work on this. And I'd like to thank all the participants who joined us for this webinar. It was extremely informative. If you missed any portion of this webinar, please log on to shieldhealthcare.com/community. It will be posted by the end of the day tomorrow. Thank you, everybody. Have a great rest of your day and a great rest of your week. Thank you very much, everyone.
Thank you, Eric.